All right. Wow, what a massive room for such a perfectly formed crowd, right? We can't see you very well, but if you came closer down the front, it would be even better. We had imagined we would be in a small room for this talk, and we find ourselves in like what feels like the Colosseum. So I hope you're more friendly than the Romans or the lions. So shall I introduce myself and then you can introduce yourself?
Sure.
Yeah, so my name's Robin. I have the great pleasure of being the Deputy CEO and one of the Executive Directors at Safer Care Victoria.
Welcome to you all. I'm Lisa McKenzie. I am the Regional Director with the Institute for Healthcare Improvement across the Asia Pacific region, and it's fabulous to actually be able to do these in-person events after so long of seeing people on a screen, and now this kind of weird excitement about people's heights that I never thought was one of the things that we'd find so interesting, but here we are.
Brilliant. So, shall we get started while people are, I think, still slowly scooting in? So, as I said, I work for Safer Care Victoria, and I'm going to give you just a tiny bit of background about Safer Care Victoria before we get into the great theory that Lisa will step us through, and then I'll give you the examples of the work that we've been doing. Again, we'd imagine we'd be in a really intimate space to have this conversation with you and that we'd be able to have an interaction. Now it feels a bit more like a terrifying lecture from my perspective anyway. So please, if you want to say something, put your hand up and yell at us. While the house lights are on, we can't see very much beyond the first 1 or 2 rows. So really help us out and make sure that we get as much as we can out of the next 45 minutes. So before we get any further into this, I do want to acknowledge the traditional custodians who have lived and loved this land through the vastness of time. Now, ordinarily, I would specifically acknowledge the Boonwurrung people of the Kulin Nation, and I'm going to do that because I live there every day of my life and appreciate the great wisdom that they provide into the land that I love. So Safer Care Victoria started in 2017, so we're pretty new kids on the block when it comes to quality and safety. And we have a really, I think, laudable vision and laudable purpose. We were born out of a review of the health system in Victoria, which was called Targeting Zero, and it was stimulated by a number of really, really unfortunate deaths of babies, as is often the case with these kind of things. And we were really set up to tackle variation, which I know that many of you will have and be from organisations that have the same purpose. So there is a gap, essentially. The way we think about variation at Safer Care Victoria is that there is a gap between what we know and what we do. Really simple frame, I think, from the IHI, in fact. There is a lot to know nowadays, a lot to know. Imagine 30,000 medical journals published per annum. That's just the journal, let alone the articles. How is it possible that we can keep on top of what is best practice and the debates that are forming the care that we provide? And certainly in Victoria, we have an incredibly fractured data system because we have 74 independent public sector organisations and I think a total of 300 providers of acute care. So we have a lot of data, not a lot of information probably, if we're honest, but lots and lots of data. So there's a lot to know in order to deliver care. And there is a massive gap between what we do with that information. And variation of care is the outcome, which often leads to harm repeated in multiple places. And certainly low value care is part of that conversation as well. And so we've been working together with our colleagues at the Institute for Healthcare Improvement on whole system quality, which is largely depicted in this rather clunky 1980s kind of a vibe, isn't it? But certainly. It's super important to the way that Safer Care thinks. So I'm going to hand over to Lisa to talk us through whole system quality.
Excellent. So we've heard a little bit of the background about Safer Care. And now what we want to do is actually get to know a little bit more about you. So I'm going to ask our technicians if they could turn on the lights on you instead of us. And I'm hoping it stays that way for the rest of the presentation. But also because it'd be great to see your faces. But I am going to be asking you 6 questions about your organisation's journey to whole system quality. And in asking these questions, I want you just to think about a 5-point scale And I'm going to describe what it means to get around about a 0 on the scale, so bottom of the scale, and then I'm going to describe what it looks like to get about a 5 on the scale. And so then what we'll get you to do is actually reflect on where your organisation sits on this 5-point scale. Technical crew, are you able to turn on the light so I can see more than one gentleman in the second row? And if not, Robin will be my eyes.
Miraculously I can see, yep.
Because clearly we can't actually change the lighting. That's okay, no problem. So first question, how does your organisation engage with consumers? So kind of more towards the bottom of the scale, around a 0. Do you predominantly seek feedback and review complaints, and you have them on your committees? Not all committees, just some committees. Sometimes you're worried it's a little on the tokenistic side, and it's more around informing your quality activities, but not to any great depth. But if you're more on the 5 side of the scale, what we want you to do is, for that, that's where you really truly partner with consumers and families and communities to understand what matters most to them, and where they are actually co-designing and co-producing every aspect of your service and your system. So if you just think of that 0 to 5 scale, what we want you to do is hold up your hand and give yourself, don't overthink it, give yourself a no halves, just a 2, 3, 4, 5, whatever it might be, about where your organisation is currently at. And Robin can let us know where many of you, 2s and 3s predominantly.
Yeah, there's a couple of 5s though. I'm fascinated to know how you get a 5. Do you think we could ask?
And we'll keep diving through. Second question, who predominantly influences your quality goals? Is it mostly external pressures? So that might be the media, accrediting bodies, governments, might be your wild ambitions to be in the top 100 hospitals in your country or in the world, who knows? If that's the case, more towards the 0 of the scale. Or 5, do you really understand what matters most to those you serve? The consumers, the patients, families, your communities? And then do you internally set those quality goals to try and best meet those needs? 0 to 5, whereabouts are you around your quality goals? I like that the 1 and the 4 are sitting next to each other, so I think there's a conversation that needs, just have a little look around as well. So low scores, look at the higher scores, high scores, look at the lower scores, because these are the conversations we need to have if we really are going to be transferring some of this knowledge, and as we talked about this morning. Third question, do you have a deployment strategy to support quality? So is quality activities mostly outsourced to a quality department that looks a little bit like this? Might be one or a small group of people who really don't have the necessary supports or resources or infrastructure to really make quality happen across a whole organisation. I could see that big fat 0 that you just gave. Or are you on the other end of the spectrum, where everyone from kind of the board to the bedside really understands their roles and responsibilities around delivering quality. And there is sufficient resources and infrastructure, and it's really clear around the governance structures that are in place. And there is investment in building the capability of staff and others so that people actually have the skills needed to be successful. So if you're in a 5, it sounds like a nirvana, doesn't it? But let's have a look at what sort of scores for this question.
There's a
bit
5.
more, ooh, 5 over there. Bit more central though, more 4s and 5s, so that's good to know.
2s, a couple of 2s.
A few 2s. Does your culture support psychological safety and learning? So on the 0 end of the spectrum, do staff and consumers feel like they're not able or feel very unsupported when voicing their safety concerns or their ideas for improvement? Is it a very reactive feeling environment where staff particularly are constantly kind of reacting to issues and incidents and firefighting, but not enough time is spent on moving upstream to try and understand the kind of system issues that might be contributing to these incidents occurring so that we can actually prevent them from occurring. And sometimes are staff actually blamed for these incidents rather than there being, adequate focus on the systems that are also contributing? That case, you'd be towards the zero end. But on the other end of the spectrum, around the fives, do you actually have a culture that does support psychological safety and that continuous learning, where you really do understand about when things not only go wrong, but you also are focusing on when things go right, so that you can more consistently provide high quality care every time, where staff actually have the infrastructure around them to be able to proactively predict risks and incidents, so they are being able to make sure that they've got the necessary systems in place to be able to provide high quality and safe care. What about for this one? Where would you be placing? Fours. Oh, this is good. A little bit higher scores there.
2s and 3s on this side.
2s and 3s on this side. Fifth question. What data is used to inform quality? Do you usually use intermittent monitoring of data, often looking in the rear mirror and using retrospective data, and looking at static displays of data where, bar charts, traffic lights, those sorts of displays of data, and for some reason, that data isn't transparently shared across the organisation. And there's a little bit of an over-reliance on audits and accreditation type activities to try and understand what the quality is like in your organisation. Or do you have more real-time data that is transparently shared, where you're looking at dynamic displays, where you're looking at statistical process control charts and run charts, and you're really able to understand variation in your system in terms of the quality of care, and that all staff have access to this data, and it is, informing what they're doing around their improvement work and also their safety work, and really driving quality at every single level of the organisation. And even thinking about things like predictive analytics, you're actually on that path as well, being able to predict when things may go wrong and be able to, again, be upstream around it. Then give yourselves a 5. So whereabouts are you for this fifth question?
Oh, wow, there's 4s.
And a load of variation
and there's
here.
some people like me, 1s.
A few 1s. Excellent. Last question. What's your approach to quality improvement? Is it 1,000 flowers blooming, where you've got a whole heap of QI projects? And that sounds like a good thing, but it's a whole heap of QI projects that maybe are not really addressing what matters most to those you serve, and maybe not really that well aligned to some of your high priority quality goals. And then is there a bit of a kind of fix and forget mentality where I describe it as sustainability being a bit of an issue. So you might spend a lot of focus on the delivery of projects, projectitis, some people call it. But then what happens over time is that things start to return to the kind of status quo, as you can see from this picture. Or alternatively, more on the 5 end, do you use system design for quality, where you've just got a small set of very focused but highly prioritised QI projects that are addressing what matters most to those you serve? And then there's a really systematic way to testing change ideas and implementing them, and then sustaining them, putting in the infrastructure so you can hold the gains over time, and then spreading them across your entire organisation. So you end up with this much more beautiful, thoughtful, well-designed field of flowers or QI projects like you can see in this picture from Holland. Where would you place your organisation? Oh, 0? 2s, 4, again 5s. I really do think there's some conversations that needs to happen in that row, lots of variation. Oh, 2s. Excellent. So that's the last of our questions. And what we want you to do is just, again, reflect on the types of answers that you've given. Are you sitting more in the kind of 0-1s foundational building, where there's a lot of room to try and strengthen your approach to whole system quality? Or were you predominantly in the kind of 4s and 5s, so quite advanced in the way you're thinking about quality? Or was there a lot of variation? Some of the answers might have been 1s and 2s, some of them 4s and 5s. Because what we're going to be doing now is actually spending the rest of our time together about thinking about what needs to shift, what needs to change if we're going to move from this very reactive, piecemeal approach to quality to a much more proactive, coordinated and whole system approach to quality. And so what I'm going to do is provide a bit of the theory, and then Robin is going to make that theory come to life and provide a more descriptive part of showing how Safer Care Victoria has done this in practice. And so the combination will hopefully mean that it becomes a lot clearer. So how can we actually close the quality gap? Firstly, what we need to do is be really clear on our current state. How is our organisation currently performing? Then, where do we ideally want to go in the future? What is going to be needed to best meet our consumers' needs and wishes? And once we're really clear on both our current state and that desired future state, there is a quality gap that's going to be created. And once we know what that quality gap is, as an organisation, we need to be really clear on what our vision is for the future, and then put forward a strategy that's actually going to help us close this quality gap, and also make sure that we've got clarity on the values needed and the way our staff are going to interact to actually help and support us to do this. And that's going to help us actually close the gap between where we are now and where we ideally want to be. Just having a strategy alone isn't enough. What we need to also do is have an enabling environment, a culture, and a way, a method of actually making it all happen. And that is where this very antiquated triangle comes from, and it's old for a reason. I will describe why. But this triangle, known as the Juran trilogy, because it was invented by Dr. Joseph Juran, is made up of quality planning, quality control and assurance, quality improvement, and then systems to actually support continuous learning. But we're going to dive a little more deeply into how these parts integrate together. But I did just want to point out that this whole process is cyclical. So you're constantly reviewing how you're going in terms of your current state. You're constantly reviewing what you ideally want to be providing in the future. And this allows you to be really responsive to emerging issues. Who would have thought, 2 years ago that we would have been facing the pandemic that we did? So this is not a set and forget exercise. It requires constancy of purpose, and it requires organisations to constantly be thinking about where do they ideally want to be as they set their strategy. So let's dive a little bit more deeply into this way of making it happen. So you can see the photo of Dr. Joseph Juran, and I'm assuming given the kind of conference we're at, there are some quality zealots in the room. But Dr. Juran was extremely influential in so many quality management approaches. And this was something that he had developed back in basically the 20th century. In fact, his work was prolific for the entire 20th century. He was still consulting in his 90s. Not something I'd aspire to, but I mean, that is phenomenal. And he lived to be 103. So the whole of the 20th century, he was working on techniques and management approaches like this. Now, despite it being designed for industry, it has shown to be so impactful in healthcare and in organisations in the community as well. So, and it's really stood the test of time. There is a little, despite the triangle looking very simple, there's a little bit of complexity into how the components interlink and are interrelated. And so I wanted to walk you through this graphic just to try and make a bit of a point about what these different parts mean. So just to orientate you to this graph, and so those of you who like graphs will love this, those of you who don't, I'll apologise in advance. But on the x-axis is dollars. And imagine that as millions of dollars wasted due to poor quality, due to errors and incidents and things going wrong. And so dollars on the x-axis and then time on the y-axis. So basically what you're wanting, the direction of goodness is down. You want to reduce those unnecessary costs due to poor quality. So before an organisation even begins, that's where quality planning comes into play. So that's where you need to understand who your customers are, was the word that Juran used, but we'll say consumers in healthcare, but often there's a little tussle about who is the customer. And once you're clear on who the customer is, you need to understand what is going to actually meet their needs, what matters most to them. And then in quality planning, you need to set really clear goals for how you're going to meet these needs. And once you've set these goals in quality planning, you then need to set your organisation up for success, which means putting in place policies and procedures and guidelines, all that infrastructure, making sure you've got the right staffing resources, making sure they've got the right capabilities, but this is all setting things up for success. Then the organisation starts operations. Now, again, I will make the point that this isn't static, so you'll see how these things interlink, but let's just go with the purest theory. So the next part is quality control and assurance. And this is where you're constantly monitoring how your organisation's performing over time and comparing it to the quality goals that you set in quality planning. And where you see that something's happening that isn't aligning with what those quality goals are, your frontline teams need to be in a position where they can actually, firstly, notice that something's going on because they're monitoring that data all the time, but secondly, then respond and actually make the real-time adjustments to be able to reduce the error rates or respond to any of the issues or incidents that are occurring. So in this graph, you can see there's suddenly a little spike. Anyone want to guess? You can yell out what might have happened in this spike. It's just a hypothetical. There's no wrong. Accreditation. Let's hope not, because let's just say, hopefully there's no junior doctors in the room, but let's just say that is a spike that has occurred because you've just had this big influx of junior doctors and you've just had an increase in medication errors across the entire hospital. And so what will happen here is that your frontline teams would notice there was a change in the data, and then they would then go, whew, this is not good. What we're going to do is we're going to bring those junior docs in. We're going to use our standard work, those guidelines and policies that we actually set in quality planning. We're going to tell our junior docs about our medication reconciliation processes and administration processes. We're going to make sure they've got the skills they need. We're going to teach them about our EMR, and whew, look at that, isn't that great? We've just seen the quality go back into alignment with what we consider high quality. So mostly, our frontline teams can actually make those real-time adjustments. They're doing it all the time. But sometimes the needs of consumers might change, or sometimes the issue might be so great that the frontline teams actually can't do it alone. And that's where quality improvement comes into play. So quality improvement is a very structured approach to redesigning your system to be able to actually achieve better and new levels of performance. Now, I mentioned that this is all interlinked, and you can see down the bottom there is a loop back in terms of lessons learnt. So when you do quality improvement, hopefully you'll have results that look like this, and you achieve this new level of performance. But what we don't want to see happen is that the results aren't held and you don't hold those gains. So there's a loop back to quality planning, because you may need to do things like adjust your policies or guidelines. You might need different training systems. You might need other things to try and make sure that you are sustaining those improvements over time and you're able to actually achieve that new level of quality. So that's how it all comes together, and that's how that antiquated looking triangle hopefully will make a little bit more sense around the very important roles and complementary nature of the way the system actually works. We've left this slide in here really just as a resource for you. There's an IHI white paper about whole system quality. So anyone who really wants to learn more and know more, please just view the reference at the bottom of this slide, but you can go very, very deep into this topic. But we wanted to recognise the important role that different levels of the organisation actually play, from patients and families to middle managers and to board members. Again, if you wanted to spend a little bit more time, because each of these very important components, everyone has a particular role to play in quality planning and in quality control and in quality improvement. So that's the theory part. And now Robin has the, I'll say, slightly more challenging part of talking about how to make some of this real and make it happen on the ground. So back over to you.
I'm seriously regretting referring that to an old triangle, but it does remind me of something we might have done in the original PowerPoint days, the triangle.
It's true. Probably the overhead projector, possibly.
The overhead projector, that was awesome, wasn't it? I had a high school teacher that was allergic to chalk, which was also one of those. She must be delighted now that things have moved digital. Anyway, so I'm going to talk about our journey, and I'm going to go through the questions Lisa has asked you because I think they're kind of helpful. We are different though from a bricks and mortar hospital. We operate as across a whole state, which makes even answering the very first question tough. But we've been super busy, and this is just a sort of list really over the years of the different things that we've tried. And some things we've tried have been totally terrible but seemed like good ideas at the time, and some things we have tried have worked out surprisingly well. So I'm going to talk through some of these kind of big ticket items as we go through these questions. So these are the things I'm going to start with, are the things that went well or are going well at the moment, and they largely fit in the quality improvement and the quality planning part. And that's because we started off by drawing on the things that we knew were going to be helpful and that we had in place already. So the consumer engagement, quality goals that matter, strategy and operations, and the purposeful quality improvement I'm just going to talk through in a little bit more detail. So who is Safer Care Victoria's customer or consumer is a really tough question to answer, because we sit sort of across the state in this kind of umbrella-like body who tries to influence the very people that are actually treating the patients or their family or their carer directly. However, where we have had opportunity, work directly with consumers, and we try and increase that opportunity almost every connection that we have. We started off doing two things. We stood up a patient and family council, it was called. It feels like so long ago I've forgotten its name. But it was set up in the kind of guise of hospitals all have their consumer forum, and I think if we were being really honest with ourselves, most people don't know what to do with that cohort of people. We know that it's super important to engage with them, but very often we don't get beyond tick and flick, and Safer Care fell into that trap almost immediately. They did, however, generate one really important product, which is the Partnering in Healthcare Framework. And I don't know whether Louise McKinley's in the audience today. Hopefully she's not. But if you see her around, she was the brains behind and did all of the hard work as the executive, as the director involved in this work. But we co-designed it with hundreds and hundreds of consumers to make sure that what we were recommending to the state and recommending to health services was exactly right. And as I said, we've moved away from that kind of standalone committee to one that is actually made up of all of the consumers that work with us in Safer Care. And we have lots now because they lead our improvement initiatives together with our clinician leaders, recognising the importance of that lived experience in making sure that we stay on track when we do improvement. We do employ some full-time or part-time consumers into our team to make sure, again, that we're kept honest. We have them on our review teams that go in and look at hospitals that aren't having the best of time when it comes to delivering care. And we also have them as part of our Fellows program, which I'll talk about in a minute. And we're starting to stratify them based on their skill and contribution. So not every consumer is the same in the same way as not every clinician is the same or every executive or director. They all come with different skills, and we're trying to place them in those places. We have ones that are great at governance and they come and join our committees. We have ones that are great at telling an impassioned story and bringing an audience towards an improvement initiative, and we try and use them in that way. So we no longer think about consumers as a singular entity as well. And then we do also consider our clinicians as part of our kind of consumers of our work. And we've established a Fellows program that started in 2018, which brought in 8 full-time clinicians to work with us on improvement initiatives across the system for 2 reasons, really. First of all, they were really great to work with and made us closer and closer to the bedside, which is super important when you're hanging out in government. But they also learnt what it was to be part of a whole system, not just staring at the patient list that they have in front of them. And they have gone on to take on really fabulous roles across the state, and indeed actually in New South Wales, some of them. And we've expanded that program just this year to around about 100, so a massive step up. We have clinical leads who we've both got working as key specialists in the improvement work that we're doing, but they also operate as advocates for the system into government, which is really important, particularly when you think about what we've been through in the last 2 years. And we have huge network forums that come together with somewhere between 100 and 200 people on the line learning together, which is also a part of the shift towards a learning health network, which you see diagrammatically on the left-hand side of the slide. So we've come a long way. I would never say that we reached a 5 though. I'm really intrigued to know the people that did and what we can learn from you today. On to the next question, which is around our quality goals. Now, if you've been created as a result of a massive, great big tome with hundreds and hundreds of recommendations, that pretty much drives everything you do for the first 18 months, and just about every spreadsheet was filled in by us and each recommendation ticked off. But it's still a pattern working in government. We've had the recent Royal Commission, and that drives the mental health improvement program that we have embedded inside of Safer Care, making a difference at the moment to suicides and restrictive practices. So we have a slightly less autonomy perhaps than a health service, who I can see there's a CEO in the audience from Victoria. Hello. He may argue with me that he doesn't have that much more autonomy than I do, but nonetheless it sometimes feels like you guys do. But we've got better and better at directing the work that we're doing. So we have the 100,000 Lives campaign, which is built around key points of variation in the system. But there are, and that hopefully also feed to the needs of our organisations, because they focus on things like hospital-acquired complications, reducing readmissions, and in supporting consumers to stay at home with chronic disease, which is again getting more and more into that consumer frame. Our approach to quality improvement was pretty much like the slides that Lisa showed you before, with like so many, 189, and I think that's actually an underestimate of the amount of work that was happening across quality improvement in the state. It's hard to, but 189 small pieces. So at one organisation was there a great piece of work happening, but it was not connected to somewhere else that had the same problem, going back to that variation piece that I started with. And then we moved into doing collaboratives thanks to our partnership with the IHI, and we started with the Delirium Collaborative, and then we moved on to ones in maternity. Better Births was about severe perineal tears and reduced perineal tears in 294 or 49. I can always get that muddled up. But anyway, quite a large number of women, around about 250, don't have a severe perineal tear as a result of 12 months of significant effort by a team. Safer Baby Collaborative was done both at a local level for reducing stillbirths in Victoria, but also fed into the national work that's happening across Australia through the research actually in this very city. And then we've moved on to slightly harder things to do, which I think the Healthcare Worker Wellbeing Initiative is one of those, which is the extension of the Joy in Work frame that the IHI does, recognising more and more, I think, how important our workforce is, because none of this would happen without a really healthy workforce. And then from these sort of disparate parts, we've brought them together under the banner of the 100,000 Lives in the main. So at least then we have a slightly better narrative and an understanding of the work that we're doing from the original 189. And that has taken 4 years, I think, is the other thing that's worth pointing out. This is a very, very slow way of getting your house in order, but it sticks once you start. So someone else, I think Lisa, it was your reference around strategy and operations need to be sitting together, and I think over time Safer Care's got better and better at making that connection. I just want to point out at the bottom there, it's probably a bit too blurry on the screen, but there is a way of assessing an organisation against whole system quality, and we have been doing that. We've done 2 or 3, two really purposeful goes at doing that, and you can see that we've got better and better in terms of connecting our strategy to our quality improvement initiatives, and that's largely because our strategy is actually built on Duran's trilogy. It took us like 4 months, I think it was, to realise that that was what we should do, but nonetheless that process was important. And we have, through that, then been able to build our improvement initiatives to make funding possible through the state government budget cycle. But there were things that didn't go quite so straightforward over the last 5 years, and they largely speak to the ability for us to invigorate and learn across the sector, but also to make that data really, really timely and purposeful. And as I said before, there are a lot of organisations in Safer Care and Safer Care in Victoria, and they're all autonomous. We don't have the same EMR connecting our public health systems. And that makes data really challenging. It means that you're dependent upon lag data, massive lag data. So in terms of psychological safety and learning, we have done what you would expect a state body to do. We've rolled out Just Culture training. We've improved our reporting on sentinel events. Now, obviously, that's dependent upon hospitals and health services being willing to share that information with us, and they have become more willing. We are a safe place for concerns to be raised with us, which means that we must be doing something right. People, when they're in trouble in their health services as individuals, ring us up and have a chat with us about what they're seeing happen to their consumers of their healthcare provision. And as I mentioned already, we have the Healthcare Worker Wellbeing Initiative, which goes beyond the BTS Collaborative or the piece of work we're doing with organisations to also providing information and stimulating conversations. But I definitely don't think we've got anywhere close to a culture that supports psychological safety and learning from what goes wrong and right. We have a long way to go organisationally and as a state to get there. And then do we really, really use the data that we have in the government system to inform quality? And I absolutely don't think we do. And in part, that's because it's so lag. But in part, it's also because you enter into a trust, I don't trust the data, there's something wrong with it, it's not quite right, blah, blah, blah. All of the really good reasons never to use any data to make a difference. The other thing we haven't done is connected our data part, just simply in our organisation, which is only 120 people. We have not managed to connect the people that are looking at the data to the people that are doing the improvement initiative successfully. And so over the last couple of months, we've been really deliberately trying to do that. But it's hard because it's human behaviour, isn't it, to just stare at your work in a pandemic when you're working from home for 2 years and just worry about your own work and not think about how it could actually impact on somebody else's. Culturally, we're in the right place. Everyone, when you do those staff surveys in Safer Care, all say, I'm here to make a difference, I'm here to make a difference. But actually that connection between, oh, I've discovered this problem, oh, I know how to help with that problem, doesn't happen naturally inside our organisation. And so then it becomes really, really challenging to think that you could have that happening across the whole system quite smoothly. So the things that I really want you to think about in terms of lessons from our experience is that need to make sure the strategy and the operations of the organisation sit together. We haven't, like I said before, just minutes before, we haven't successfully done that at Safer Care Victoria. In a tiny organisation of 120 and sometimes if we're really lucky a few more people, we haven't managed to have that strategy which is going in this direction towards whole system quality, always connected to operations. And we are working hard at the moment to do that. There have been other factors involved as well. We've had huge staff turnover, which I'm sure everybody has experienced in their organisations. And that means it's really important to stay on that relentless focus of what you're trying to do and how you are trying to do it. It does take time. We are 5 years along here, and actually when we assess ourselves, we are nowhere near the 5s and 4s I've seen in this audience. We reckon we're a sort of, sometimes a 1.9 or a 2, or perhaps if we're really lucky, a 2.5 and a 3. So I think it takes time and relentless focus on what you're wanting to change. And we did focus on improvement and our planning areas at the start. And now we are turning our attention to that data and that integration between the quality control, quality assurance, and the improvement part. And I think once we get that happening over our next strategy, over the next 2 or 3 years, then I think we may well actually be stepping towards our actual vision of outstanding healthcare for all Victorians, always. And I think that reflects the third point, which is around starting with your strengths. And they were our strengths. We had great engagement and we worked really hard with our clinicians and consumers. So that was a really easy thing for us to step forward with. It was also quality improvement. I mean, who doesn't like quality improvement? It's fun, you make a difference, it's all about change, you get to hang out and do fun workshops, and you can actually see that tangible change as a clinician in front of you, which is really positive. But data is much harder, and that's what we're going to focus on over the next couple of years. So just to remind you where we started this conversation, we are trying to get to a proactive and whole system quality approach, and we are using our 1980s triangle to do that. But it requires hard work. And so I would ask you, having listened to us now, and if we were in a nice little intimate session, I'd sidle up to someone who'd smiled at me during the presentation and ask them a specific question, but we're going to have to rely upon you guys to help us out now, is really, what is your next step? What is it that you think you need to do in your organisation or as leaders of the quality and safety system in your sphere? What is it that you're going to do next to try and bring this kind of concept into play? Because I'm fairly clear, but I'm also fairly convinced that this is the right way to think about how you make that system change. So we are reimagining our strategies. I've already kind of alluded to while you think about your next steps towards measurable safety outcomes. And we are trying to get our capability teams fully integrated towards clinical governance, because we think if we get the clinical governance working, which is basically the business of healthcare, is it not? I mean, it always, I'll just go off on one if you don't mind. It amazes me that we think that clinical governance is something off to the side. It is actually the whole purpose of the organisation, not necessarily making money, you know, it's about actually the clinical governance of an organisation. And so we're trying to integrate that inside of our organisation so that we can support our CEOs and our clinicians to do a great job. And the other part that's been really obvious through the pandemic is that Safer Care's relied upon a very oral, in-person existence. We have depended upon being able to talk to each other and pass on our standard work and the way that we do work inside the organisation. And it is very clear as a result of working online for 2 years that we need to focus on our standard work. What do we do when someone rings up and says there's a problem at X hospital? What do we do if there's a bit of a wonky quality improvement measure that comes in? We haven't got that in place as an organisation written down so that people know, and we're going to be working on that. So I'm going to stop because I am hoping that I've padded enough now that someone will have a question or a comment or something that they'd like to commit to as they leave this auditorium. Did you want to make a final spiel, Lisa?
I think you have summed it up beautifully. I think let's just circle back to where Robin started about this kind of knowing doing gap.
Do you want to go back there?
And why don't we go back to the antiquated triangle? But the knowing doing gap is very, very real. This theory has been around for decades and decades, and despite this theory being so proven to be successful, it's very, very challenging to make it happen at a whole system level. And so we've been working with partners around the globe and trying to support people to actually make and strengthen whole system quality. But what we would really love you to do is, as we transition to the next incredible presenters, sorry, you never want someone to set the bar too high before you get on the stage, do you? Apologies for that. But as we do a bit of a transition, it would be fantastic, especially noting the variation in your responses to those first 6 questions. It'd be great to see you connect. If you notice someone sitting near you, especially our friends over here, but someone sitting near you where you were quite low and they were very high, have a quick chat about what they're doing, but really try and commit to at least doing one thing differently next week, or one thing that you would love to see your organisation prioritise, and think about how you can influence that as leaders in the system, because it really does take that constancy of purpose that Robin was talking about to actually make this happen. And kudos to Safer Care Victoria for actually staying the course, because many organisations cannot and do not, but really to be able to have seen the progress over time is really, really impressive. So just thank you for your attention in this giant coliseum of a room, and we look forward to chatting further with you over morning teas and lunches now that we're actually in person. And we will give you a moment just to chat amongst yourselves as the next presenters come in and get themselves organised. So thank you again.